Okay, if you are following along in your book, then we are on page 1570. So if you're following along in your book, we are on page 1570. And what I can tell you is that the early signs and symptoms are very different than typical arthritis because it is systemic. So the person often has fatigue, weight loss, sometimes a fever, general malaise. They have morning stiffness. Their joints can be considered edematous, boggy, and there can be erythema at the joints themselves. There's good pictures on page 1570 that show you that's actually what's going on at the different joints. When we look at deformities that are caused by rheumatoid arthritis, look at page 1571. So look at page 1571, and you can see, for instance, A, that is an example of ulnar drift that can happen in the hands. B is what we call boutonniere deformity, which also happens in the hand. You can get hallux valgus, which happens in the feet, and then swan neck deformities, which also happens in the hand. As the disease progresses, because it's systemic, then the patient can become anemic, and from the anemia be pale, have color changes in the joints, have joint deformities, and obviously decreased mobility, and you can see how they're going to have contractures, dislocations, and increased joint pain. Okay, if you look at page 1572, there's a table 65-7 that kind of talks about diagnostics, or the diagnostic criteria for RA. And so it tells us that the patient has to have a joint that's involved, that they have to have some type of positive test result, whether that be, for instance, a negative RF factor, rheumatoid factor, and a negative ACPA, or maybe they have a high rheumatoid or a high ACPA, or maybe they have one of those that's even low. Just one of those they have to have. And then it talks about normal ESRs versus abnormal ESRs. And then how long has this actually been going on? So it's difficult sometimes to diagnose rheumatoid arthritis. There's no one test that's always positive in the population. Even the rheumatoid factor is only positive in 80% of the population. So sometimes they have to just take all the different symptoms that the patient's experiencing and diagnose them based upon that. Then you get into, once we diagnose that you have you are positive for rheumatoid arthritis, we need to go ahead and get you started on some medications. And so the drugs really that we need to talk about, we need to flip back a little bit in your book. So if you guys would go back to page 1565 in your book, go back to page 1565 in your book, and let's talk about, first one are the salicylates, such as aspirin. We're not talking for rheumatoid arthritis normal aspirin therapy. These people can take 1-2+ grams of aspirin a day. So they obviously are great anti-inflammatory and analgesics, but it can also cause a lot of issues. We know that the salicylates or aspirin actually inhibit the synthesis of prostaglandins. Well, prostaglandins utilized in the stomach to give it prostaglandin gives the stomach that protective factor. So ulcerations, gastritis don't occur, and so that's actually blocked. And so it's very important that aspirin is taken with food, possibly milk and antacids, lots of water, and that we need to tell these people they need to watch for any signs of bleeding because it does decrease platelet aggregation. We actually need to check platelet counts and liver studies. Non-steroidals are very similar. We know that they are also great anti-inflammatory analgesics. With these guys too, give with food, milk, possibly antacids. Once again, watch for signs of bleeding. Check the kidneys. There are some different types of NSAIDs, COX-1 versus COX-2, and the COX-2s are a little bit easier on the stomach. It talks about the topical analgesics. That's just different creams that someone with rheumatoid arthritis could utilize, but we're not going to go into those. Flip the page to 1566. Injections, steroid injections, can be useful when there's a significant flare-up, but obviously long-term chronic steroid injections are not a good idea. Then we go down to the DMARDs, the disease-modifying anti-rheumatic drugs, the DMARDs. Most popular, we'll learn the methotrexate and the sulfasalazine. These guys are actual drugs that are going to possibly cause your patient blood counts to drop and white counts. So we must watch the red blood cell count, the platelet count, the white blood cell count. We must watch both hepatic and kidney function. These guys need to let us know if they have any issues that suggest that they're having anemia. People that want to be or are pregnant cannot take DMARDs. Need to let them know that the urine might turn orange. We talked about evaluating for hepatic function, teaching the patient signs that their liver's not working properly. And then we talked about what labs need to be monitored. Next, we go down to the gold compounds, and that's like your gold salts. You can take these orally or get injections. They are supposed to suppress the immune response and therefore suppress active rheumatoid arthritis. So once again, cannot use these in pregnancy. Must watch the CBC, hepatic and renal functions. Can take a long time for therapeutic effect. The antimalarials, such as Plaquenil, can be used for rheumatoid arthritis, and once again, we're watching the same things. Then we get over to your tumor necrosis factor inhibitors. These are the newest ones that are on the market. This is your Enbrel, your Remicade, your Humira. And these guys also block with the tumor necrosis factor and help decrease the inflammatory response at the joints. We want to make sure that they're working. These lower the patient's immune system. We need to let them know that they're at increased risk for developing tuberculosis and that they should have a yearly PPD. And that they also should need to monitor the injection site and watch for a localized reaction. These are the drugs that we're going to learn for rheumatoid arthritis, and we need to always follow up and evaluate. Are they helping? Is there a decrease in the pain, a decrease in the swelling and the stiffness? Is there an increase in the patient's joint mobility, in their mobility overall? All right, so we want to relieve the symptoms these people are having and really focus on preventing joint and muscle destruction, maintaining as much joint and muscle function as possible, and that these guys can be independent and enjoy their life. So we talked about the medications already that people for rheumatoid arthritis have. We need to stress the importance of someone who has rheumatoid arthritis has a balanced program of rest and exercise. These guys need to rest daily, especially during acute exacerbations of the disease. Regular rest periods during the day are a must. Okay, and so rest and exercise is extremely important. These guys need to perform the range of motion exercises to maintain joint function and prevent contractures. Their isometric exercises to maintain their muscle strength. Isotonic exercises also help preserve muscle strength and limb function. They obviously want to have occupational and physical therapy as allowed. Heat and cold therapy can be used for analgesic effects, muscle relaxing effects. Moist Heat is often good. Sometimes this can be provided in like a bathtub or a shower. A lot of times they need assistive devices or splints, maybe a cane or a walker or a raised toilet seat. Maybe to provide joint rest, they'll have some type of splint applied. Splints also used to prevent contractures. A lot of times these guys actually wear splints at night on their hands or wrists in order to prevent contractures. As far as nutrition, a lot of times we encourage these guys, no special diets, sometimes just, increase fatty 3 acids, such as what can be found in fish oils. Make sure they're getting plenty of calcium and vitamin D. And as far as surgery goes, a lot of times we're going to talk in osteoarthritis about scopes and joint replacements. It's often very similar for someone who has rheumatoid arthritis. All right, a couple of the nursing diagnoses. Chronic pain. These guys are considered chronic pain because they have obviously pain for more than 6 months. So we want to monitor the level of pain, monitor the duration of the morning stiffness that we've talked about. The pain and the morning stiffness are good indicators of their disease activity. Do we need to change anything? Is it getting worse? Is it getting better? Encourage them to think about how does their pain relate to activity levels and adjust accordingly. Also teach them hot and cold applications to provide relief. Talk to them about, getting in the shower, taking baths, warm compresses, using cold therapy, and just seeing which one is more therapeutic for them. How to use their prescribed anti-inflammatory medications and their medications overall. And, encourage non-pharmacological pain relief measures, visualization, distraction, meditation, etc. Fatigue. Fatigue is huge with RA. It's a systemic disease. It disrupts the patient's sleep pattern. It causes anemia, muscle atrophy, sometimes even poor nutrition. So we want to encourage them to balance periods of activity with rest. Stress the importance of actually taking rest periods during the day, prioritizing what exactly needs to be done, and what's most important, do it early in the day, and to encourage regular physical activity. Ineffective role performance. This can obviously interfere with the patient's ability to pursue a career or fill other roles, such as being a parent, a spouse, a family member. So we just need to discuss the diseases and in relationship to the patient's career and how it's affecting their life. Encourage them to talk to their family about it and how it's changed the roles, and listen actively. And then disturbed body image is pretty much straightforward. We've talked about the different types of contractures, disfigurements that can occur with rheumatoid arthritis, and so just encourage them to verbalize the effects that their disease has on both the physical and on their life roles. Encourage them to maintain self-care to the extent that's possible, and refer them to any type of help groups that might be available in the community.